30 minutes after an uncomplicated spontaneous vaginal delivery of a newborn term, a 22-year-old primary gravid woman after sudden onset heavy vaginal bleeding. After sudden onset heavy vaginal bleeding, pregnancy and labor were uncomplicated. Prior to the onset of the bleeding, the placenta delivered spontaneously with non-tapering vessel extending to the margin of the membrane. Examination now shows no vaginal or cervical laceration. The uterus has a moderate tone and consistent in size with 24 weeks of gestation. Which of the following is the most likely diagnosis? There is no pain, isn't it?
No pain. No. Why is this
30
doing
minutes
this?
after. Okay, there are.
Staff doctor received heavy vaginal bleeding. The placenta deliver
You already
contaminant
did
tapering
delivery at
uterus of not return position is usually successory placenta lobe to the margin of the membranes. I don't know what that means. There's too much going on. Placenta was delivered. The placenta that develops separately from the main placenta. Okay. Although they are connected via fetal vessels, they can be one or more accessory lobes. It is associated with first trimester bleeding, polyhydramnios, placenta previa or vasa previa, blood or placenta, postpartum hemorrhage caused by retained placental tissue. Okay, risk factors include advanced maternal age, leiomyomas or fibroids, previous uterine surgery. It can be diagnosed by ultrasound and is commonly managed by C-section as a result of high risk of maternal and fetal mortality associated with hemorrhage when discovered antepartum. If, however, it goes undiagnosed until delivery, the mother may require oxytocin and manual extraction of the placenta and accessory lobes. It's not placenta BC, placenta accreta or placenta percreta refer to abnormal attachment of the placenta to the myometrium or through the serosa and potentially adjacent organs, okay, respectively, rather than just the decidual endometrium. It is commonly diagnosed prenatal ultrasound but can present postpartum hemorrhage because of retained placental tissue. What is the key here? How do you know it's
succinturate placental lobe.
Duriet placental lobe?
It commonly presents
Yeah,
with
what is
like
the key in the
PPH.
question?
It comes with PPH because of the retained placenta and it is associated with placenta previa, vasa previa, and placental abruption.
Hmm. So it's not the placenta little one. Okay. But what is the key in the question that says, okay, this is not placenta accreta or percreta, is the succintoria?
In placenta accreta and
Oh,
percreta. So,
maybe because they.
yes,
Go
you
ahead.
tell me.
Maybe because they said that the placenta did deliver. It says
After delivery, yes.
is that they deliver spontaneously in vessel extending to the margin of the member. I think that's the key. I just don't understand the sentence, but I think that's the non because he said that the placenta delivered, so it cannot be placenta accreta or pecreta because it's already
Perfectly, yes.
delivered. It's already out. Yeah, it's already out of the stomach. But then they said that there is some kind of vessel in the margin of the membrane. I think that's it. That's what they're trying to say. It just doesn't make that much
This is the key, like non-tapering vessel.
vessel.
Non-tapering vessel extending to the margin of the membrane. This is a classic description. This one is the I have
Okay.
got this from Gemini. I am sending you the actual
Oh.
explanation. Okay, okay, and then I'm reading this. Okay,
Okay.
what happens in here? Like they actually specifically say that non-tapering. This line is written like non-tap, isn't it? Like non-tapering vessel
Mm-hmm.
extending to the margin of the membrane. This is a classic description of succenturiate placental lobe. A succenturiate lobe is an accessory lobe. We know that the placenta is connected to main placenta by blood vessel. If these connecting vessels are not torn when the main placenta delivers, they can continue. So they can continue to bleed, or the succenturiate lobe itself may be retained, leading to hemorrhage. Like you deliver the placenta,
Okay.
but as there is accessory lobe, some of the lobe is
Mhm.
present inside the inside the uterus. That's why there is bleeding. And why other option is less
Okay, so it's
likely?
kind of this vessel, this one.
Sorry, yeah. Which one? Yes,
Mm-hmm.
yes, yes, yes.
It's
This
like
one.
this one.
Yes.
Oh, this one. This vessel. Mm-hmm. Got it. Got it. Oh,
And other option
okay.
like
Okay. This one.
placenta abruptio placentae, not usually 30 minutes after an uncomplicated delivery with an spontaneous delivered the placenta. In case of
Mm-hmm.
abruptio placenta, and in placenta accreta, uh, in the scenario it has written that placenta is delivered spontaneously, so it is not
Mm-hmm.
accreta. And parcreta is
Mm-hmm.
actually perforates and goes to the myometrium as far we remember. So it is not
Mm-hmm.
parcreta, and it is not placenta previa also.
Mm-hmm.
So the key is non-tapering vessel extending to the margin of the
Yeah.
membrane. Okay,
Yep.
so we need to
Okay.
remember
Makes
this
sense.
word,
Yeah. Okay.
non-tapering vessel extending to the margin of the membrane. Okay, next. A previously healthy 19-year-old woman comes to the physician because of 2-day history of fever, chills, and severe burning, vulvar pain with urination. She is sexually active. One male partner doesn't use contraception. Her temperature is 38.5, 101.3 degree Fahrenheit. Pulse is 110. Respiration 14 per minute. Blood pressure is 110 by 60. Examination show bilateral tender firm inguinal lymphadenopathy. Bilateral tender firm inguinal lymphadenopathy. There are several erythematous coalescing labial vesicle bilaterally. Which of the following is the causal organism? So,
Right. Is that is that herpes or do cry?
hmm,
Does do cry makes you cry?
Ducry can cause vesicle. That is the only concern. Do cry has do you cry painful ulcer.
Oh, it's ulcer. It's not vesicle. You say.
Yes.
So herpes has vesicles. But does herpes has pain, lymphadenopathy
Yes,
pain?
it can.
Yes. Okay. Okay. Herpes. Okay. Ready?
Yes. I haven't seen you have highlighted the herpes answer.
Right is I oh I
Okay.
didn't. Sorry. Yes.
I thought that
This
this is
patient
communication problem. Okay, you haven't actually.
no no. No, I hadn't actually. But now you do you see I'm on the answer already?
Yes.
Okay. These patient vesicular lesions on the labia are likely due to HSV in the form of genital herpes, which also commonly cause fever, chills, lymphadenopathy. Infection typically begins with the formation of vesicles, which lies and progress to painful ulcers with red borders. Okay, so vesicles to ulcers. Genital herpes often causes vulvar pain with urination because of the irritation of the vesicles and later ulcers. HSV1 and 2 are both members of the herpes virus family of double-stranded DNA enveloped virus. Genital herpes is most likely for by HSV2, but can also be caused by HSV1. In contrast, herpes labialis is most often by HSV1, but can also be caused by HSV2. For infection with both strains is possible. Genital herpes is transmitted to sexual contact and perinatally. HSV may be latent in the sacral region, Sarcoganglia until reactivation when it causes painful vesicles and erosions in the genital with associated inguinal lymphadenopathy that is painful too, I guess. Systemic manifestations are also possible, including viral meningitis and encephalitis. Treatment with herpetic infections. Treatment for herpetic infections includes drugs like DNA polymerase, viral DNA polymerase. Drugs that inhibit viral DNA polymerase, like guanosine analogs such as acyclovir, valacyclovir, famciclovir. It's not which one was there. It's not lymphogangloma venereal. That's Chlamydia trachomatis subtypes L1, L2, L3. Presents with small, painless genital ulcers. Ulcers are painless and tender inguinal lymphadenopathy. These patients has painful vesicular lesions. And it's not chancroid because chancroid has chancroid which presents with exudative, painful genital ulcers with inguinal lymphadenopathy. It is caused by Ducrey. This patient has red vesicular lesions, which are more classical of herpes. So chancroid is ulcers and lymphadenopathy that are painful. Okay. Okay. Next.
Okay. Next. A 21-year-old woman, gravida 1, para 0, aborta 1, comes to the emergency department because of vaginal spotting and lower abdominal pain for 3 hours. She is sexually active, does not use contraception. Menarche was at the age of 13 years. Mens occur at regular 30-day interval. Her last menstrual period was 6 months ago. Pelvic examination shows slightly blood-tinged vaginal discharge. There is cervical motion tenderness with a firm cervix and a closed cervical os. Uterus is firm and tender and consistent with size of 6 weeks of gestation. The right adnexia is tender. Urine pregnancy test is negative. Which of the following is most likely diagnosis?
Jeez. Hmm. Hmm. Ready?
Yes.
Okay. Uh, menstruation. An ectopic pregnancy often presents with vaginal bleeding and abdominal pelvic pain. Ectopic pregnancy is abnormal pregnancy in which the fertilized ovum implants in the fallopian tubes or the ovary within the peritoneal cavity or in another non-endometrial location. Beta HCG is produced by the placenta. Beta HCG is produced by the placenta is undetectable in the serum of non-pregnant patients and doubles approximately every 2 days during early normal pregnancy. Serum beta HCG concentration does not increase as expected in ectopic pregnancy, often lagging the normal um, doubling. Ultrasound can be used to confirm the intrauterine pregnancy and may visualize an ectopic pregnancy. In a normal pregnancy, an intrauterine gestational sac should be visible by 5 weeks. Gestational age on transvaginal ultrasound or when the beta HCG concentration exceeds like 1,000 to 2,000. Ectopic pregnancy is non-viable. Ectopic pregnancy can be managed medically using methotrexate for small early pregnancies, but may require salpingectomy or evacuation with laparoscopy for larger pregnancy. In cases of medical treatment failure or in any case of complication, yeah, okay. Complications of ectopic pregnancy, rupture, bleeding, hemoperitoneum, severe cases can result in hemorrhagic shock. It's not hemorrhagic corpus luteum cyst because can occur when a corpus luteum does not involute following release of the ovum during menstrual cycle. The cyst can rupture and cause peritoneal irritation and abdominopelvic pain, but will less likely be associated with vaginal bleeding and positive. Yeah. It's noted that the uniform moles are caused by fertilization of an empty egg by a single sperm or followed by duplication uh, or by dual fertilization of normal ovum. They typically present with vaginal bleeding, nausea, vomiting in the first trimester, and uterine size out of proportion to expected gestational age. Here she's 6 weeks and is 6 weeks. Okay. It's not PID, typically presents with fever, mucopurulent and cervical discharge, and cervical and anusal tenderness. Anusal tenderness may present in cases of tubervagin abscess. So what was the key here?
Urine pregnancy test is positive, one key,
Mm-hmm.
and uterus is firm, non. Okay. Mm, one is urine pregnancy test is positive, and her last menstrual period, so she is pregnant. First thing, she is pregnant, and as we haven't done the um, I just picked up in that way, like in ectopic pregnancy, you
Mm-hmm.
actually do it by confirming the ultrasonograph where there is no gestational sac, isn't it?
But okay, so here it says that so even if you have a ectopic pregnancy, your uterus is still become big. Because here it says that the uterus is consistent in size with 6 week gestation. So even if the pregnancy, the thing is implanted in the adnesa in the ovary, the uterus is still growing in size.
Yes.
Okay. Okay. I didn't know that. Okay.
It is very like slightly confusing explanation. L-
N- I
Uh,
just thought that because the pregnancy is implanted somewhere else in the fallopian tube, whatever,
yes.
then the uterus does not become big. But okay, 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 I
Oh,
got it.
I got it. You are what you are talking about. Like if it is implanted at other side, why uterus is
Uh-huh,
consistent with the size of the gestational age. That's the
uh-huh,
thing you are talking about, isn't it?
uh-huh, uh-huh. Yeah.
I don't have that answer.
Okay.
Very tricky question. I don't know actually.
But normally the uterus should the uterus be growing even if it's ectopic pregnancy?
Sorry.
Should but normally like should the uterus be growing even if it's ectopic pregnancy? The uterus should be growing too, like normally.
Probably, probably,
Okay.
probably,
Okay.
because uh, oh, okay. I don't have that explanation. Don't try to be over smart. I don't wanna.
Okay. Okay, I just wanted to make it, yeah, okay. Okay then. Okay. Next.
Okay. A healthy 32-year-old primary gravid woman, 8 weeks of gestation, comes for her first prenatal visit. She has achondroplasia. She does not use tobacco, alcohol, or drugs. She works as a chef 10 to 12 hours. She is 3 feet 6 inch, 3 feet 6 inch, weight 36 kg, pulse 72, blood pressure 106 by 60. Examination show uterus consistent with the size of 8 weeks of gestation. Examination of the pelvis show conjugate diameter 7 centimeter, intraspinous diameter 5 centimeter, intertuberous diameter 5 centimeter. Ultrasound show a fetus 9 weeks of gestation. Her hemoglobin is 9.9. Urine analysis show trace protein. The patient is at great risk for which of the following?
She has low hemoglobin,
Sorry,
so she has low hemoglobin, so she's at risk of what? That's the only thing that's weird. I don't know.
he has a trace protein also. You have,
Trace protein, okay, but
and
for blood pressure,
blood pressure is normal. He has that is the key. No PE. You
well,
are
well, it's not normal. It's kind of low though, or
so
no?
is it
But
rupture can happen?
why? Blood pressure is low, hemoglobin is low, so not renal. Looks like, oh no,
How you are?
I don't,
It can. I don't know.
because I don't know. Oh, sis, I don't know. Okay, pick something. I'm picking.
Okay, we both are wrong.
Both are wrong. Look at the way you said it. We both are wrong. Okay, achondroplasia is autosomal dominant disorder of abnormal long bone growth. Abnormal long bone growth. Okay, with minimal effect on the cranium as a result of a mutation in fibroblast growth factor receptor 3. It is the most common cause of dwarfism. Oh, they're short. Because the disease is autosomal dominant, this patient fetus has 50% chance of developing achondroplasia with associated macrocephaly. Okay, so the head is big and the body is short. The
Yes.
normal measurements of an adult female pelvis are 10 to 12 conjugate. Oh, God, I'm not going to remember that. 9.5 to 11 intraspinous diameter and 10 to 11 intertuber, making this patient pelvis much smaller than would need for the successful passage of the fetus through the pelvic inlet and outlet during a vagina. Okay, so the mom is little, so the
Yes.
fetus won't be.
So
Achondroplasia
mom
does.
is little, baby will not gonna come out. That's why we will doing cesarean delivery. That's the take home.
I get, yes. Achondroplasia does increase the chances of fetal arrest during descent, whether her child has achondroplasia. Okay, so even if the child is normal, it will still be hard for the child to pass because the mom thing is little, which places the patient at greater risk for requiring a cesarean delivery. Okay, okay, okay. Fetal achondroplasia carries 50% likelihood given the autosomal dominant inheritance. However, given the patient's small pelvic size, C-section will likely be necessary regardless of the presence of achondroplasia. It's not renal failure because renal failure presents with symptoms of uremia, fatigue, nausea, pruritus, abdomen status, hyperkalemia, hypervolemia. It is not typically a complication in pregnancy in a patient with achondroplasia. Okay, okay,
Okay, next.
next.
Okay, a 47-year-old nulligravid woman comes to the physician because of two episodes of heavy vaginal bleeding during the past 3 months. Menarche was at 11 years. She has 4 to 6 menstrual period each year. Moderate flow. She has type 2 diabetes mellitus, treated with glyburate hypertension, treated with hydrochlorothiazide. She has never received hormone therapy. She is 5 foot 4 inch, weight is 79 kg. Temperature is 98, pulse is 88, respiration is 22, blood pressure is 150 by 98. Pelvic examination shows a small amount of blood in the cervical os. Small amount of blood in the cervical os. Which of the following is the strongest risk factor of the endometrial cancer? So,
Hmm.
how many children?
Ready?
She is nulliparous, isn't it?
Nulliparous, yeah.
Okay, let's see.
Oh, Jesus. Nope, we're wrong. This one is hard. We keep getting all the questions wrong. Risk factors for endometrial cancer include chronically increased estrogen concentrations, we know, unopposed estrogen therapy, chronic anovulation, obesity, estrogen secreting tumor, and endometrial hyperplasia. Exogenous sources of estrogen include systemic estrogen therapy and tamoxifen. Endogenous sources of increased estrogen include chronic anovulation, obesity, estrogen secreting tumor like granulosa cell tumors. Chronic anovulation is the strongest risk factor for endometrial cancer in this patient, as she presents with history of irregular menses for decades, which will indicate a prolonged history of anovulation. Anovulation results in the abnormal increased production of estrogen, as progesterone is primarily produced by corpus luteum after ovulation. Oh. The patient's chronic anovulation has likely resulted in persistent abnormal endometrial turnover, in which chronic estrogen production unopposed by progesterone has caused proliferation of the endometrium. Hmm. This results in endometrial hyperplasia, which places the patient at high risk of endometrial cancer. It's not, where was I? I was
It's not
looking for C and
nulliparity. Yes.
yeah. It's not nulliparity has been shown to also increase the risk of endometrial cancer because of the lack of gestational period, which typically serves as an extended time period without cyclic endometrial proliferation and menstruation. The more menstrual cycles a patient has experienced in life, the higher risk for endometrial cancer. Wait, the more menstrual cycles, the higher risk for endometrial rate.
Endometrial
Yeah.
cancer.
So why is it non-nulliparity? Because that means he has a lot of menstrual cycles. Oh, because she only has like 6 per year. So she
Okay.
doesn't have the normal like 12. So she doesn't really have that many
That's why chronic anovulation.
and ovulation. And it's not early menarche and late menopause can be associated with increased risk of endometrial cancer. The association between early menarche and endometrial cancer is not as strong as chronic anovulation, which directly results in chronic unexposed estrogen. Okay. Okay. So if it wasn't chronic anovulation, it would probably be nulliparity. Okay. Got it.
Okay. Okay.
Okay. Ready.
A 32 year a 32-year-old woman, a 32-year-old woman, gravida 3, para 3, comes to the routine health maintenance examination. She has used a copper IOD. She has used a copper IOD for contraception for 2 years. Examination shows enlarged uterus and a visible IOD string. A pelvic ultrasonograph shows the IOD near the fundus, adjacent to 4 mm intramural leiomyoma uteri. The endometrial cavity is normal in size. Which of the following is the most appropriate next step in the management?
Okay. Ready?
Ready?
Yeah.
Okay.
Is leave the IUD in place, but inform the patient that the fibroid may cause heavier menses. Leiomyomata uteri, also known as fibroids, are benign neoplasms of uterine myometrial smooth muscle and common tumor in women. They most commonly present with vaginal bleeding, pelvic pain, and miscarriage or infertility that can sometimes be asymptomatic. Physical exam will disclose an enlarged irregularly shaped uterus. Subserosal fibroids are the most common and can alter the exterior diameter of the uterus. Intramural fibroids are located within the wall of the myometrium, and submucosal fibroids extend into the uterine cavity, abutting the endometrium and altering its shape. They are all typical what's visualized on pelvic ultrasound. They are estrogen responsive and increase in size with pregnancy and decrease in size with menopause. Treatment options for symptomatic fibroids include NSAIDs, combined OCPs, GRH agonists, and surgical options such as myomectomy and hysterectomy. In this particular case, as this patient fibroid is asymptomatic and there are no alterations made to the shape of the endometrial cavity, okay. It is appropriate to leave the IUD in place for long-term pregnancy prevention, but to inform the patient that the fibroid may cause heavier menses. It is not B. Remove IUD and recommend another contraceptive method is not necessary at this time, as this patient IUD is positioned properly in the endometrial cavity and not altered in shape by the fibroids. Okay. Its efficacy is not affected by the presence of um, the fibroid. And it's not E. Reposition the IUD further from the fibroid to maintain effectiveness of the IUD is not necessary, as the T shape of the copper IUD is unaltered by the presence of the fibroid, intramural fibroid, and thus its effectiveness is unlikely to be altered. Mm.
Okay.
So wait, so if the shape of the inside the endometrium was abnormal, then we should remove the IUD?
Uh,
Is that
Probably. Like like if it is displaced, then there is chance of pregnancy.
if
IUD
the
is,
IUD?
yes,
Mhm.
if IUD is displaced, like not in the normal position, then there is chance of having pregnancy. So then we should remove the IUD, because
Okay,
she has put this IUD for
pregnancy
inhibiting the
prevention.
pregnancy.
Mhm.
Okay.
Okay,
A 27-year-old woman gravida 3 pounds to the physician because of tenderness of the left breast for 2 days. She has been breastfeeding for 2 weeks. Her temperature is 39. Her temperature is 100.1. Examination of the breast show erythematous hard tender in the upper quadrant. The nipple has fissures. Which of the following is the most appropriate pharmacotherapy?
ready?
Yes.
So it's the closaxilin.
What's
Mastitis
that?
refers to cellulitis. cellulitis of the breast, usually because of bacterial introduction from microtrauma during breastfeeding at the nipple, presents with unilateral red, indurated, edematous, warm, tender breast tissue. It is frequently associated with fever. It is treated with continuation of breastfeeding and oral antibiotic. Mastitis is most associated with Staph aureus and less with Strep pyogenes and Strep agalactiae, Haemophilus influenza, and E. coli. Effective antibiotics include dicloxacillin and cephalexin. Or dicloxacillin is commonly chosen as a result of its efficacy against beta-lactamase producing bacteria such as Staph aureus. It's also safe during breastfeeding, as there are no demonstrated adverse effects and it only passes into breast milk to a small amount. It manifests if mastitis continues untreated, it may progress to breast abscess. It's not ampicillin will not be ideal choice because of resistance. Beta-lactamase producing bacteria hydrolyze the beta-lactam membrane of the antibiotic and are thus resistant to earlier generation penicillin and aminopenicillin such as ampicillin. Okay,
Okay.
next.
Yes. A 25-year-old newly-gravid woman comes to the physician with her husband for counseling prior to contraception. They are planning to start family next year and would like to know their risk of having a child of Tay-Sachs disease. She is a French Canadian and has some distant cousins who died during early childhood. Her husband is Jewish, but not the Ashkenazi descent. He has no known relatives with Tay-Sachs disease. Examination of the patient shows no abnormality. Which of the following is the most appropriate next step in determining Tay-Sachs disease in future children? Tay-Sachs disease is what? Autosomal recessive.
I don't know. I don't know. Mm, They sucks. I don't
Can you
know.
can you tell me a significant incident of recent about French Prime Minister?
French Prime Minister.
Yes, Emmanuel Macron.
Oh, the president, the one where his wife slapped him.
Yes. Okay.
Yeah, I saw the video. Oh yeah, I saw the video. He said they were just playing. That is funny. Okay. If possible, I don't know this word.
I think that
Next.
like wife is the main. If she is
Okay.
negative, then we don't need to do anything.
Okay. I think it's B.
Like the wife of the macro is the main.
Okay.
Okay.
Let's check. You are right. Tay-Sachs autosomal recessive.
This
You're right. Lysosomal storage disease, for which preconception testing is recommended for patients who, from high risk population. If testing of the high risk patient is negative, no testing of the spouse is indicated since the child will have no chance of developing the Tay-Sachs disease due to its autosomal recessive inheritance pattern. High risk population include Ashkenazi, French Canadian, Pennsylvanian, Dutch, Cajun population. Oh, Lord. Since this is French Canadian tested first. In Tay-Sachs disease, a genetic mutation causing a deficiency of the exonaminidase A enzyme leads to accumulation of the cell membrane glycolipid GM2 ganglioside within neuronal lysosome. A negative DNA test indicates a wild type allele for the XA enzyme, which will produce enough XA enzyme to degrade the GM2 ganglioside. Tay Sachs disease presents with normal motor development in the first few months of life, followed by progressive loss of motor skill, muscle spasticity, macrocephaly as a result of accumulation of GM2 ganglioside in the brain, and characteristic cherry red macular spot. Ultimately, blind seizure and fatal aspiration pneumonia as a result of pharyngeal muscle weakness result and typically limit the expectancy to between 2 to 5 years. Okay, so it's autosomal recessive. Okay.
Okay,
Mm-hmm.
next.
Mm-hmm.
A 16-year-old girl comes alone to the physician requesting advising regarding contraception. She states that she is planning to become sexually active for the first time. She is planning to become sexually active for the first time with her boyfriend, and she requests an oral contraceptive. She has no history of serious illness, takes no medication. Mens occur at regular 28 days interval. Physical examination shows no abnormality. In addition to counseling about STD prevention, which of the following is the next step in the management? Uh,
Ready?
yes.
So, prescribe low dose contraceptive. We did not see that one coming. The landmark U.S. states, the landmark United States Supreme Court case Carey versus Population Services International 1977 affirmed the right of minors to access contraceptive services. Most states do not require parental consent in order for minors to be prescribed OCPs by physicians or to purchase them. In the case of this teenage patient who is requesting oral contraceptive, it is most appropriate for the physician to provide information and counseling on contraception and to provide uh, a prescription. Variety of contraceptive methods are appropriate, including oral, injectable, hormonal contraceptive, or IUDs of subdermal implant devices. Is not C. Where am I? Performance of testing for chlamydia and chlamydia and Neisseria is unnecessary in this patient who's asymptomatic, who's not currently sexually active. While teenagers are at increased risk for STI, including chlamydia and Neisseria, screening for this infection is not necessary prior to initiation of oral contraceptive. Teenage patients who are starting contraceptive methods should be counseled that these methods do not prevent STIs. Oh, okay, okay, okay. Next.
So while low dose oral contraceptives,
I don't know why it's low dose, but I guess yeah, you have to give them. I didn't pick that one because of it said low dose. I was like, what is low dose? I don't know what that means.
I thought it's
Uh,
C.
I thought it was C2. I picked C2. Oh, didn't I pick? Oh, I didn't. I didn't. Yeah, but I picked C2. But I didn't pick that. I knew, yes, you have to give them the contraceptive because even if she's, STI contraceptive, mental thing, you have to give them, even the parent is not there. But because they said low dose, I was like, okay, maybe that's not, yeah. But yeah, they say it's not chlamydia. You don't test for chlamydia or gonorrhea if the patient is not sexually active or if she doesn't have any signs like vaginal discharge or all these things basically. And she's not sexually active yet. She's going to. He was
Yes.
saying that she wants the contraceptive because she's going to become sexually active. Yeah. So I guess that was the key here.
Okay.
Next.
A 27-year-old woman gravida 2 para 2 comes to the physician for advice regarding contraception. She is sexually active with two male partners and does not use contraception. She does not want to become pregnant now. She has DVT during the second pregnancy, and she is not certain if she would like to have more children in the future. 3 months ago, she was treated with chlamydia trachomatis infection. She currently takes no medication and reports that she has had difficulty remembering to take daily medication in the past. Her blood pressure is under 10/70. Physical examination, including pelvic examination, shows no abnormality. In addition to advising the patient to use condoms, which of the following is the most appropriate recommendation regarding contraception? She has difficulty remembering take daily medication. Remember. She is not a heavy. So DVD. Okay, okay.
Oh, she has DVT.
So we can use IUD. Copper IUD can be used. We cannot
Yeah,
give
okay.
like the hormonal things which
Mm-hmm.
contain estrogen. Okay, let's see.
Oh shit! This
We
this
can
person.
give put retroxyposition. So they are actually there are two types of IOD: copper IOD and like hormonal IOD.
Oh, you're
This is
trying
a
to say because they didn't specify it here. They didn't
yes. This
specify
is
which one here.
a tricky question.
Oh,
Okay, we
this
fall
CMS
into
is
the
like
trap.
depot progesterone is an intramuscular subcutaneous progestin, so it's progesterone only, that persists for 14 weeks. It's hormonal contraceptive and prevents pregnancy, 96% effective, by causing a sustained release of progestin, which prevents ovulation and causes thickening of the cervical mucus and thinning of the endometrial layer by inhibiting GRH, FSH, and LH, and estrogen production. It is often used as a method of contraception for patients that have a contraindication to estrogen therapy, history of DVT, okay, particularly if a patient is non-adherent to daily medication, as progestin pills require a strict daily schedule to be effective. Contraindications include hypertension, diabetes, ischemic heart disease, unexplained vaginal bleeding, and chronic corticosteroid use. Complications include delayed return to fertility, decreased bone mineral density, and increased risk for diabetes. It is not, which one was that? E. Placement of IUD where the copper or progestin containing alters the uterine environment to make it unfavorable for implantation of an embryo. They are extremely effective at preventing pregnancy and last like 3 to 10 years. However, they are contraindicated in a patient with history of recent genital tract or risk for STI infection. So she just had chlamydia, so you cannot give this. It's
Okay,
not vaginal contraceptive ring combined. Those are combined that have estrogen and progesterone. They are less effective in preventing pregnancy, require placement monthly, or you have to replace them monthly, and are contraindicated in patients with DVT. Okay, got it. Got it.
okay. Next.
Mhm.
A 52-year-old newly gravid woman comes to the physician for a routine health maintenance examination. She feels well and has no serious illness. She feels well and has no serious illness. Means occur at regular 30-day intervals. She received all appropriate uh, childhood immunization, but not since that time. She has never had sexually active, but plans on becoming sexually active with her boyfriend. Physical examination shows no abnormalities. Prior to discussing contraceptive options with the patient, which of the following vaccine to administer?
Jeez. It's Neisseria, varicella. I, eh,
She has received all appropriate, but not since that time.
so one that you're supposed to receive when you are older, when you are baby and when you are older. Oh, It's not flu because they didn't say anything about the timeline. That it is seasonal. Mm,
But we can
I
talk
don't know.
about the seasonal antibiotic. Sorry, seasonal vaccine.
But I feel like if it was flu, they would have gave like it's the September. She came to see the doctor in September and blah 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 and all these things. I'm between
eh,
HPV. We say it was 21 to
49,
65. Oh wait, it was 65 or
49.
49.
Isn't it 49?
It was
As far I
oh shit,
remember.
I forgot. And this is Neisseria. Wait,
She
this
she is
meningococcal is
not
nice
not
living in
immunocompromised.
any, yeah. No, and she doesn't live in any like dorms and all these things. And then it's varicella. No, I think it's HPV. I'm not sure. Okay, just pick one.
I have picked influenza.
This okay. Okay, let's see. You're right, it's influenza. Oh Lord, this the CDC. I suck at this one. The CDC and the RCIP recommends a yearly influenza vaccination for patients older than 6 months. The influenza vaccine is available in inactivated, recombinant, and live attenuated forms. The only absolute contraindication to receiving the vaccine is a history of Guillain-Barré syndrome and previous dose of influenza vaccine. I didn't know that. The live attenuated vaccine should not be used in patients who are immunocompromised, like HIV, immunosuppressant medication, asplenia, pregnant, or that have a cochlear implant.
6 weeks.
Okay. Seasonal influenza is responsible for a high rate of morbidity and mortality because of its complication of pneumonia with acute respiratory distress syndrome, myositis, myocarditis, as well as multisystem organ failure. Annual vaccination is required as a result of high rate of mutation of the influenza vaccine, influenza virus, which results in a decreased host immunity. It's not HPV vaccination recommended for outpatients 9 to 26 years and is occasionally administered up to 45. You were right. So it's 9 to 45. It is an important vaccination for the prevention of infection with HPV, the high risk strains. Okay. It's not meningococcal vaccination recommended for patients living in house, in college dorm, military barracks, those with asplenia, those traveling to countries with epidemic meningococcal, like in Africa. And it's not varicella vaccination is recommended for patients that lack immunity to varicella, were born after 1980 and did not have chickenpox as a child. As this patient is 52, varicella vaccination will not be recommended. Okay, I
Okay.
need to write them. So HPV is
Within
9 to
45.
46 to
Na-
45 years old.
yes.
HPV vaccination. Okay, next.
Do you have that vaccine schedule like USPTF something that
I feel like I've seen it somewhere. I don't
I
have it.
have
Is
that.
it on
Sorry.
the one that has a lot of colors?
Yes.
I had it. I have it. I cannot look at it. It gives me a headache when I try to look at that.
Like, can you give me? I have read it earlier, but I do not know. But I have lost it. Like UPSTF
It's
something
not.
like.
Is it not in a circle or it's not the same?
No, no, it's not the inner circle one.
Oh, it's not in the
There is
circle one.
another one.
Which one then? I thought it was the one that has a lot of colors. Mm, there is one that has like a lot of colors. Mm, hmm.
Like which one?
It's usually, I think I can even find it. vaccine schedule, and it's USPFD maybe. Yeah, that one that has a lot of colors like this, isn't it?
No, not like that. There is another,
Okay,
like a full 3 to 4 page of something. I have that, but I don't know.
okay,
Oh, I have lost it somewhere.
okay. No, I was talking about one like this that had these colors.
Okay, if I find it, I will send it. Okay,
Yeah.
no problem. Let's study. That things actually give us headache, but we need to see that before going to the exam. Okay, an 18-year-old primary gravid woman at 18 weeks of gestation comes for second prenatal visit. Abdominal examination show uterus that measures 23 centimeter above the pubic symphysis. She has gained 4.5 kg since her last visit 4 weeks ago. So, 4 weeks ago. Okay, sorry. Mm, His blood pressure is 120 by 72. Fetal heart tone is 160 per minute. Urine dipstick is negative for protein and trace positive for glucose. Which of the following is the most appropriate next step in the management?
Hmm. Ready?
Yes.
Oh my lord, hate this thing. It's ultrasound for dating. Fundal height is often used to um, estimate gestational age. The distance in centimeters between the pubic symphysis at the top and the top of the uterine fundus, pubic symphysis and uterine fundus approximates the gestational age in weeks. Typically, gestational age is calculated from the last menstrual period. When there is a discrepancy between those two measurements, the most appropriate next step is management. In management is ultrasound to assess the gestational age of the fetus through objective parameters for accurate dating. Measurement of the fetal crown rump length, biparietal diameter, femur length, and abdominal circumference can be used to accurately date a pregnancy. Ultrasound guided gestational age measurements are the most accurate during the first trimester. Okay. Ultrasound can also determine the other causes for a fundal high larger than expected, including multiple gestations, high for moles, and fetal microsome. It's not B, nutritional counseling is not necessary as this patient is gaining the appropriate amount of weight for her pregnancy. Typical weight gain for a patient with normal BMI is like 25 to 35 pounds over the course of the gestation. Okay. It's not glucose tolerant test typically completed at 24 to 28 weeks gestation to screen for gestational diabetes. This patient is only 18 based on the last menstrual period or 23 based on the fundal height. Okay. Making either scenario too early for glucose tolerance test. Okay, got it. Next.
Yes. A 32-year-old woman, gravida 3 para 2, delivers full term 4 kg newborn vaginally. The pregnancy was uncomplicated despite receiving oxytocin therapy in the recovery room. She has excessive vaginal bleeding and a boggy uterus. She has excessive vaginal bleeding and a boggy uterus. The bleeding continues after uterine massage. Which of the following is the most appropriate next step in the management?
Mm,
Uterine massage.
You already did the uterine massage, the oxytocin. What is next? Uh, is it ergos? Oh no. Oh, I hate this CMS. This was a tough one. Okay, ready?
Yes.
This is a tough one. Like, okay, I got this at least. Uterine atony typically presents with postpartum hemorrhage and a boggy uterus. Okay, on physical exam, as in this patient, initial management involves IV fluid administration, uterine massage, and oxytocin, and evaluation for other causes of PPH, like cervical laceration. If uterine atony persists despite these interventions, carboprost, prostaglandin, or carboprost, or prostaglandin, or methylergonovin, and ergot can be given. Okay. Carboprost is contraindicated in asthmatic patients as it may produce bronchospasm, whereas ergot um, therapy is contraindicated in patients with a history of hypertension and coronary or cerebral artery disease. Okay. Ergot works directly on the uterine smooth muscle, inducing increased uterine tone to sustain tetanic contraction, which reduces blood loss and is an effective treatment for postpartum adrenal atony. It can potentially cause arterial vasospasm, which may result in deleterious side effects in patients with history artery disease or arterial disease like coronary artery cerebrovascular disease. Further interventions to manage the hemorrhage associated with uterine atony include tamponade balloon, blood transfusion, uterine hypogastric artery embolization, or hysterectomy. Risk factors for uterine atony include macrosomia, multiple gestation, prolonged labor, uterine infection, and spinal anesthesia.
Okay, the
Um,
main flowchart for postpartum hemorrhage due to uterine atony, like in this case,
mhm,
first, if we found PPH, postpartum hemorrhage, like we can calculate or estimate postpartum hemorrhage by estimated blood loss more than 1000 ml or bleeding with hypovolemia. So if PPH and there is soft boggy uterus, the first step is uterine massage and high dose oxytocin. Though in
mhm,
here high dose oxytocin has not given, so it may be the first answer, high dose oxytocin. And
mhm,
the step 2 is the tranexamic acid, and step 3 is like uterotronic agents like methyl argonovin, like this one, argonovin. It is a second line uterotonic drug you can give, but argonovin cannot be given in hypertension. It is contraindicated if the patient is hypertensive. And carbopost can be given, but it cannot be given in asthma. And misoprostol, these three drugs can be given in case of uterine atony. And the step 4 is balloon tamponade, and step 5 is laparotomy. You got my point?
got it.
Okay. So there is a flow chart.
Mhm,
So I have told from here. Yes, this one.
mhm. Okay,
Okay, we need to remember.
perfect. Next.
Yes. A 27-year-old woman, a gravid to para 131 weeks of gestation, has constant moderate pain in the right flank for 12 hours. Her temperature is 101. Her temperature is 101. A catheterized urine sample specimen 15 to 20 RBC high power field and 32 20, 15 to 20 RBC and 30 to 40 WBC high power field. Ultrasonography of the kidney show no abnormality. The uterus are markedly dilated and the right are more than the left. The uterus are markedly dilated and the right are more than the left. Which of the following is the most likely diagnosis?
Mm,
Okay.
okay. The answer is pyelonephritis, fever, chills, flank pain, are classic findings of the diagnosis of pyelonephritis, an infection of the kidney that commonly results from retrograde spread of UTI. UTI are much more common in women because of the shorter urethra and favorable regional environment for bacterial growth. If untreated, bacteria can travel up the ureter to infect the kidney, resulting in pyelonephritis. Pyelonephritis typically presents with dysuria, flank pain, and associated systemic symptoms are fevers, rigor, nausea, vomiting, myalgia, arthralgia, fatigue. On exam, patients with pyelonephritis typically demonstrate high fevers, tachycardia, leukocytosis, and severe tenderness. Urinalysis in pyelonephritis often shows more than 10 white blood cells, may also demonstrate red blood cells as evidence of mucosal inflammation and white blood cell cast. Bacteria are generally seen on microscopy, with gram-negative rods being the most common. Pregnant patients are at high risk for urinary tract infection, including pyelonephritis, as a result of stagnation of urine from progesterone-induced decreased urethral motility and mechanical compression of the ureters at the pelvic vein, bladder, and urethral orifices by the gravid uterus. It is not D or E. Renal vein thrombosis may occur in patients with underlying thrombophilia and can present with flank pain, hematuria, and acute kidney injury, or may be asymptomatic. It will not cause fever or dysuria. It's not urethral calculus, typically present with colicky, unilateral flank pain radiating to the groin, and with gross or microscopic hematuria. The common type of UTI, the common types of urinary tract calculi are calcium oxalate and phosphate, ammonium magnesium phosphate, and uric acid. On urinalysis, RBCs without casts are common. It will not cause fever, dysuria, pyuria, unless there is concomitant infection. Okay.
Okay.
Okay. Next.
An otherwise healthy 22-year-old woman comes to the physician for 4 months. 4 months after noticing a painless lump in her breast during a breast self-examination, she notes that the lump has increased in size. She does not. Lumps has increased in size. She feels well. Mens occur at regular 20-day interval. Her last menstrual period was 2 weeks ago. She takes no medication. Vital signs are within normal limit. There is no lymphadenopathy. Examination of the right breast show raised area in the upper outer quadrant. There is no skin changes. A 4 centimeter firm, smooth, mobile mass is palpated in the upper outer quadrant of the right breast. Which of the examination of the left breast show no abnormality? Which of the following is the most likely diagnosis?
Hmm. Ready?
Yes.
That's fibroadenoma. And fibroadenomas are benign breast masses composed of epithelia and fibroblastic stromal tissue. Fibroadenomas are the most common breast tumor of young women. They present in women between ages of 25 to 40 as painless, mobile breast lumps. And they are typically small, less than 3 centimeters in diameter, mobile, and have rubbery consistency. Diagnosis may be facilitated with ultrasound or mammography. Definitive diagnosis requires biopsy, which discloses a well circumscribed mass composed of hypercellular stromal cells with a bland uniform appearance without atypia, as well as epithelial cells. Fibrinomas usually decrease in size over time and have little malignant potential. Treatment is with just observation. It's not fat necrosis, is often detected in the breast as a palpable nodularity in an area of previous trauma. On imaging, peripheral calcification is often seen. It's not G lipoma describes
Why it is
a
not fibrocystic disease?
what is it, fibrocystic changes of the breast are a benign and cyclic cause of breast pain that presents with focal masses or nodules. So it's a lot of them. Fibrocystic changes occur most commonly in premenopausal women over the age of 35. Patients may present with various sites of breast pains and lumps, which may be bilateral. So it's a lot of, not just one. It's not lipoma. Lipoma describes a benign neoplasia of adipocytes and generally presents as a solitary, painless, soft, mobile subcutaneous mass, often on the torso, so not on the breast. So mammary ductal ectasia often occurs in perimenopausal women. So, and is a widening of the lactiferous duct, often near the nipple. Ectatic ducts are often asymptomatic until they become blocked, at which time they may become nodular and painful. Okay, so like a mass near the nipple.
Okay.
Okay, next.
A 32-year-old woman, gravid 3 para to 34 weeks of gestation, comes to the physician for a routine prenatal visit. She reports that 1 week ago she had malaise for 2 days, followed by a bright rash over her cheeks that resolved within 3 days. A rash has now developed in her arms and legs. Her temperature is 37.2 degrees Celsius, pulse is 90 per minute. Examination shows a marble appearing rash over the upper and lower extremity. The lungs are clear to auscultation. Abdomen is soft. Fundal height is 35 centimeters. The fetal heart rate is 160 per minute. Which of the following is the most likely causal organism?
Hello,
Yes,
Omar.
yes, yes, I am here.
Oh, okay.
Developed on her arms and legs. Cox.
That fever and malaise. I wanted to say
Her
parvo, but why is the rash now in the marble appearing rash on the upper and lower extremities?
marble appearing rash in the
The cheeks is makes sense. Okay, fine, the cheeks. But now
sorry.
in the arms and legs, the cheeks, the rash in the cheeks, okay, and the malaise, okay, fine, it's parvo. But now it comes back in the arms and legs. Now it's not, doesn't look like parvo, or maybe. Okay, I'll
The
do.
Hansen or like in the cheeks usually happen in the babies, isn't it? And
Yeah,
in the older people comes with the joint pain, but he has not any joint pain.
joint pain. So is it rubella?
I'm
Rubella is the rash
congenital
that comes
blueberry
from what?
muffin rash.
Oh, is the blueberry muffin rash for rubella? No, then it's not that.
You are right, parvo.
It's parvo. Okay. So, parvo B19 in the context of an acquired infection while pregnant is typically a mild virus syndrome that may include a rash, fever, chills, headache, myalgia, arthralgia, nausea, vomiting, abdominal cramping, diarrhea, mild respiratory symptoms. The rash seen in adult parvoviral infection is variable in distribution, less likely to demonstrate the characteristic red cheek appearance in children. Okay. It may not be present at all. It is generally self-resolving and seldom carries a significant burden of morbidity in healthy persons. There may be consequences of maternal parvovirus infection for the developing fetus. However, if the infection is acquired in the second or third trimester, parvo B19 infection develop, especially if the infection is acquired in the second or third trimester. Okay. Parvo B19 has a tropism for bone marrow and infects erythroid progenitor cells, which can cause fetal anemia. Fetal anemia may present tachycardia, high output heart failure, hydrocephalus, and death. Parvovirus is also potential cause of fetal myocarditis. It's not rubella. Rubella infection can be asymptomatic or present with red rash, arthralgia, and fever. Fetal infection presents with sensorineural deafness, neurodevelopmental delay, cardiac defects, microcephaly, and extramedullary erythropoiesis. Okay.
During a routine health maintenance examination, an asymptomatic 65-year-old woman is found to have second degree of cystocele, and the first degree of rectocele, second degree cystocele, first degree rectocele, and the first degree uterovaginal prolapse. The right ovary is palpable but less than 5 centimeter in diameter. The left ovary cannot be palpated. The left ovary cannot be palpated. Which of the following is the most concern requiring further evaluation?
Oh. Mm,
Why they need further evaluation?
which of the following is most concern requiring further evaluation? Oh no. Everything looks like it's a problem. Hmm. Ready?
Okay.
It is the palpable right ovary. In postmenopausal women, a palpable ovary um, raises concern for ovarian malignancies. In postmenopausal women, 30% of ovarian masses are malignant. Any incident or ovary enlargement or cyst in a woman over the age of 50 should be investigated for malignancies with imaging and potential biopsy. If discovered early, an ovarian malignancy can present as a mass on pelvic exam or imaging, though ovarian cancer classically presents late in the course uh, and is often metastatic and invasive at the time of discovery. Presenting features are often nonspecific and may include weight loss, abdominal discomfort or distension, ascites, GI symptoms including early satiety, bloating, nausea, cramping, and bowel obstruction. Bowel obstruction can occur because of locally invasive disease or because of peritoneal carcinomatosis, which is a common presenting diagnosis. Ovarian cancer is potentially hereditary with an increased frequency of cases seen in women with mutations BRCA1, BRCA2 Lynch syndrome. Treatment includes surgical resection and debulking plus chemo. Early diagnosis and treatment are key to maximize survival. Pelvic organ prolapse, which includes cystocele, rectocele, uterovaginal prolapse, is a relatively common condition in older women. Cystocele refers to prolapse of the bladder into the anterior wall of the vagina. Uretrovaginal prolapse refers to prolapse of the uterus and vagina through the vaginal opening. Rectocele refers to rectum prolapse into the posterior vaginal wall of the vagina. This presentation is related to weakening of the pelvic floor muscles. Risk factors include multiparity, older age, obesity, hysterectomy, chronic constipation. Symptomatic prolapse can be managed with pelvic floor exercises, pessary, and surgical repair. Okay,
Okay.
next.
A 22-year-old primary gravid woman, 27 weeks of gestation, is brought to the emergency department because of the history of moderate back pain. Today, history of moderate back pain, fever, and nausea. Pregnancy was complicated by positive urine culture Streptococcus agalactiae. 8 weeks of gestation that results with ampicillin therapy. Iron deficiency anemia. Hemoglobin concentration is 9.9. She has not adhered to her medication regimen, iron supplementation, and a prenatal vitamin. She appears moderately anxious. Her temperature is 100.1 degree Fahrenheit, respiration 22, blood pressure 140 over 90. Abdominal examination shows mild tenderness to palpation in the right upper quadrant and right costovertebral angle tenderness. The uterus is soft and non-tender. Fundal height is 26 centimeter. The baseline fetal heart rate is 180 per minute with decreased variability. Contraction occurs every 10 to 15 minutes, lasts 20 seconds. The pelvic examination show clear mucoid discharge from the cervical os. The cervix is not dilated and effaced. Her hemoglobin concentration is 9.7. Which of the following is the most likely cause of fetal tachycardia? Okay.
Maybe. Okay. It is maternal fever. Maternal fever can cause fetal tachycardia, which is defined as heart rate greater than 160. Other causes of fetal tachycardia include hypoxia, fetal anemia, intramniotic infection, maternal medication. Conversely, bradycardia is defined by fetal heart rate less than 110 and can be caused by congenital heart malformation as well as hypoxia, um, fetal distress, and maternal hypotension. Decreased variability can be caused by fetal hypoxia, the administration of opioids or magnesium, and fetal sleep cycle, but it's not specific. Given this patient presentation, it's most likely that the fetal tachycardia is secondary to maternal fever in the setting of pyelonephritis. There are no signs of significant fetal anemia or hypoxia. It is not CD. Maternal anemia is common, especially given the physiologic adaptation to pregnancy, such as increased plasma, in addition to an increased risk for iron deficiency. Severe maternal anemia can cause premature birth and low birth weight, but does not typically cause fetal tachycardia. Maternal anxiety can cause fetal tachycardia is severe because of release of catecholamine across the placenta. However, this patient is only experiencing moderate anxiety and her high fever is most likely the cause of tachycardia. Okay,
Okay.
okay, next.
A previously healthy 42-year-old woman, gravida 2 para 2, comes to the physician because of 8-month history of severe pelvic pain and a heavy bleeding during her menstrual period. Mens occur at regular 28 days of interval last 6 days. The pain begins 2 days before the onset of the mens and lasts for 4 days. Treatment with ibuprofen does not control the pain. She has no other medication. She has had 2 cesarean delivery of her second child. Delivery of her second child was complicated by DVT. She and her husband do not want to have more children, and he is planning on undergoing vasectomy. Physical examination of the patient, including pelvic examination, shows no abnormality. Pelvic ultrasonography shows a normal uterus. Which of the following is the appropriate next step in the management? Uh, Heavy bleeding. She has heavy bleeding. Uh,
So we cannot give
Give
copper.
copper iodine. Yes.
No, you cannot give copper because she has heavy bleeding.
Heavy bleeding. We
You
cannot
cannot.
give copper iodine. Yes.
Mhm. And then OCPs. Why do we give OCPs?
OCP should be taken
I mean, I guess
regularly.
OCP.
Sorry.
She doesn't. She doesn't have an issue with taking regularly, but she don't want to have no more kids. Oh no, she has history of DVT, so no OCP. Sorry, I didn't see that. She has DVT. Never mind. Never mind.
Thrombosis,
And
uterine artery
dilate.
embology, DNC, endometrial. No, no, no.
So do we do arterial? I guess endometrial arterial embolization. I don't know what was arterial embolization. I guess okay.
Is it ablation?
I think so. Ready?
Yes.
Yeah. Yeah. Abnormal uterine bleeding refers to irregular menstrual bleeding that may be abnormal in quality, duration, and timing. It may be caused by structural abnormalities such as cervical endometrial polyps, adenomyosis, endometrial hyperplasia, malignancy, inflammation or infection of genital tract, coagulopathy, ovulatory dysfunction, endocrine dysfunction like thyroid disorders, prolactinoma, androgen, hypertrophic, or maybe idiopathic. Abdominal uterine bleeding may be treated medically or surgically. Medical approaches to abnormal uterine bleeding include estrogen, progesterone, OCPs, or levonorgestrel, IUDs. Both decrease the amount of vaginal bleeding during menses and provide contraception. For patients who are unable to take combined OCPs, do not desire future pregnancy, or fail medical management, the endometrial ablation is an option for the treatment of heavy uterine bleeding. If it is contraindicated in patients who desire further pregnancies or those with endometrial hyperplasia or cancer. Okay, endometrial ablation involves the resection of the and destruction of the endometrial lining of the uterus. It is not DNE, yeah? Dilation and curettage procedure involving dilation of the cervix, curettage on the endometrium for the diagnosis and therapy of certain uterine pathologies. It is typically performed for incomplete or missed abortion as an adjunct for endometrial biopsies. For the evaluation of postmenopausal bleeding, or if endometrial polyps are suspected. It is not used for definite treatment of abnormal endometrium. Uterine artery embolization can be used as treatment for abnormal uterine bleeding associated with uterine fibroids. It is in a patient with normal uterus on exam and pelvic ultrasound without fibroids, uterine artery embolization will not be appropriate. Okay, got it. Next.
Okay. A previously healthy 12-year-old girl is brought to the physician because of 7-day history of vulvar and vaginal itching. Vulvar and vaginal itching. She has no vaginal bleeding. Mens occur at regular 28 days of interval. Her last menstrual period was 3 weeks ago. She currently takes no medication. She is not sexually active. Examination shows mild erythema and excoriation of the labia majora. Results of the vaginal smear are shown. Which of the following is the most appropriate pharmacotherapy? Isn't it like
Oh.
bacterial vaginosis?
Mm-hmm. So it's vagina metometer, so no oral.
You are
Never
giving two
mind.
answers.
Ready? No, I'm trying to delete this one. It's not deleting. I'm trying to delete this one.
Oh,
Anyway,
Think,
whatever. I
think
get D as in
twice.
dog.
Think twice.
Cannot delete your.
Wait, wait. Think twice.
Okay. Okay. So it's B as
Apart,
in boy.
apart from these two, you
Okay. So
read
if
the
it's not
stem.
metronidazole,
Hmm. There is eating.
she's not, okay. Fine. She's not sexually active.
There is eating and
Oh,
another thing. There
so is
is,
it candida? So E
yes,
miconazole.
yes. There is germ tube. We just ignored the picture.
You ig- you want me to ignore the picture?
No, no. We need to see the picture.
No. Okay. The picture looks like it's vaginosis,
Bacterial
bacterial
vaginosis, but
vaginosis, but you say no, it's not.
no, it's not.
Okay, oh, it's not bacterial vaginosis, so it's candida.
Candida.
Okay, I did not see that one. Okay,
It is very
the
hard.
patient, but that looked like the flu cell.
That looks like
Yeah, because
clusal, true that.
it does look like the flu cell.
But
Yeah,
there is some sort
this
of
patient
germ tube, like
where
the
germ tube like
yes,
the
this one. Can you see the picture
okay,
of the germ tube in the Google?
like germ tube candida.
Is it look like
Yes,
that?
so it's like a circle with something there. No, I guess yeah. If you look at here, like there is a little circle and something, but I would have. There is no way during the exam I'm gonna look at that. Yeah, I mean you can see the little circle. Yeah, there is no way I'm gonna look at this
Apart
during the
from
exam.
looking at the germ tube,
Okay.
this question is very hard to pick up
Yeah,
because
yeah.
the itching can happen in the
Representing
yeah uh, in bacterial vaginosis also, isn't it?
India, but it's true. Yeah, yeah, yeah. This patient presenting signs and symptoms of vaginal pruritus and vulvar redness are suggestive of vulvovaginal from Candida. Vulvovaginal. Okay. While Candida species compose an element of normal vaginal flora, Candida ovego can occur and lead to um, vulvovaginitis. Candida is the most frequently associated species. Candida species as the cause of vaginitis can be distinguished from other potential causes by abnormal, often white, vaginal discharge with normal vaginal pH. They say she doesn't have any discharge on the thing. Negative KOH testing, pseudohyphae, went mouth. Candida vulvovaginitis is not a STI. Risk factors for Candida vulvovaginitis include the use of medication, especially antibiotics, and OCTs, use of intravaginal or intrauterine contraceptive devices, and immunocompromised state. Candida vulvovaginitis is treated with antifungals such as cotrimazole, miconazole, nystatin, or oral fluconazole. It is not oral metronidazole or vaginal metronidazole are all used for the treatment of bacterial vaginosis. Bacterial vaginosis can be distinguished from Candida vulvovaginitis by the presence of gray, thin, malodorous vaginal discharge, increased pH over 4.5, and fish-like odor on KOH. The identification of clue cells on wet mount preparation in diagnostic. Bacterial vaginosis is not considered a STI, and treatment of asymptomatic sexual plan is not recommended. Okay, they didn't tell us what was the key here, but okay. The guy didn't even have any discharge, so that's why it. But I guess yeah, with bacterial vaginosis, you will always see a discharge, kind of.
Like fish, like odor, fishy.
And also Here it involves the vagina and the vulva. Bacterial vaginosis only includes the vagina. Here, but she had vagina and vulva. I think that would be the key here. Okay. You want to stop here and do the biostats?
Okay.
Okay. Which one were we at? I forgot. Um,
Mm,
we were at which one? Like 18 to 20?
okay.
I'm not sure, but yeah.
Maybe.
Because I think we did the null hypothesis. Yeah, we did the null hypothesis one.
So it is 18
Eh,
to 20.
Probably 18 to 20. Yeah,
Like confidence interval.
yeah probably. I think so, yeah.
Three questions. Okay, I am reading. Not to worry.
Okay.
I will read the explanation.
Yes.
Okay. Wait. Okay. Two studies are conducted. Two studies are conducted to assess the risk of developing asymptomatic liver mass in taking OCP. Study A. Study A reports a relative risk 1.695% confidence interval 1.1 to 2.8 in women who taking OCP compared to women not taking OCP over 5-year follow-up period. Study B reports a relative risk 1.595% confidence interval 0.8 to 3.5 in women taking OCP compared with women not taking OCP over a 5-year follow-up period. Which of the following statement over the two studies is most accurate?
Hmm. The value is less than 0.05. No, that's not true. Overestimates the risk. No causality. The sample is small. Okay. Next.
A 10-year prospective study is conducted to assess the effect of a regular supplementary folic acid supplementation on the risk of developing Alzheimer dementia. The investigator reports a relative risk 0.7795% confidence interval 0.59 to 0.98 in those consume folic acid supplements compared to who does not. Which of the following p-value is most correspond the result reported by the investigator?
Okay. Next.
Why it is not 0.05?
Um, it can be, but I think it should be less than 0.05, right? To be
Like
statistically
for happening
significant.
to clinically significant.
It's statistically significant, yeah, it should be less than 0.05, right?
Yes.
I think. Yeah.
Oh, it should not be equal to 0.05. Okay. You are right maybe. Okay. A double-blinded clinical study is conducted in patients with chronic heart failure class 2 and 3 treated with ACE inhibitor and a loop diuretics. The patients are divided into two groups. One group receives metoprolol and another group receives placebo. The following relative risks are reported for the metoprolol group compared to the placebo group. Okay. Which of the following provides the best interpretation of obtained result? We don't.
Response to stroke. No. Beta blockers affect all-cause mortality. How can we to increase rates of MI? Beta blockers may exacerbate heart failure, but they decrease cardiovascular mortality. May exacerbate heart failure, but they decrease cardiovascular mortality. No. Beta blockers protect from MI infarction. What is it? MI infarction, but do not affect the risk of stroke. Beta protect from MI.
If in the confidence interval there is presence of 1, then it is clinically insignificant, isn't it?
Yes.
So stroke has 1,
It is
so it
protected.
is clinically insignificant, isn't it?
Mm, mm-hmm. Okay. Ready?
Yes. Okay, question
Okay,
1
so
answer is 4, like D. The
B.
sample size in the study B is small. Okay, why is that? Relative risk and odds ratio discussed in the previous sections are measures of association which provides point estimates of the effect. They are useful in describing magnitude of the effect. For example, relative risk of 2 indicates that the risk of outcome in the exposed group is twice than the unexposed group. Since relative risk and the odds ratio are the points estimates obtained from a random sample of the population, we need some measures of random error reported along with the point estimate. The 95% confidence interval serves this function by we by providing an interval of the values within which we can be 95% confident that the true relative risk or odds ratio lies mm, to relative sorry the 95% confidence interval serves this function by providing an interval of the values within which we can be 95% confidence that the true relative risk or odds ratio lies after accounting their random errors. For example, if a relative risk is 2.0 is reported along with the 95% confidence interval 1.5 to 2.5, we can say 95% confidence that the true relative risk in the population is somewhat between 1.5 to 2.5. As previously discussed, a value of 1 for the relative risk or odds ratio indicate there is no association between the exposure and the outcome. If 95% confidence interval for a reported relative risk or odds ratio does not include 1, there is less than 5% chance that observed association is due to chance. Therefore, the calculated p-value for such association would be less than 0.05. P is 0.03 would be correspond to 95% confidence interval 0.59 to 0.98 in the questions on folic acid and Alzheimer dementia. If the 95% confidence interval does include 1, there is more than 5% chance that the observed association is due to chance. P is more than 0.05 and the null hypothesis of no association is expected. For for example, based on the results of question 3, use of beta blocker in metabolite in chronic heart failure. Beta blocker protect myocardial infarction. Relative risk is 0.74 less than 1 with a confidence interval 0.64 to 8.5 that does not include 1. However, they have no effect on the risk factor. Confidence interval 0.86 to 1.54 includes 1. Beta blocker also protects heart failure exacerbation, cardiovascular mortality as the corresponding relative risk less than 1 with the confidence interval that do not include 1 but have no statistically significant effect of all cause mortality or all cause hospitalization as the corresponding confidence interval include 1. A confidence interval can be calculated with the mean of any continuous variable. To calculate the confidence interval, the mean, you must know the following: mean, standard deviation, z-score, sample size n. First first of all, standard error of the mean is calculated using the formula ACM, standard deviation divided by root over n. Please note the sample size in the part of the calculation. The bigger the sample size, the tighter the confidence interval. The next step is to multiply the ACM with the corresponding z-score. 95% confidence interval is 1.96. Remember, the normal distribution and the fact of 95% observation lie within 2 standard deviation from the mean. For 99% confidence 2.5. The final step is to obtain the confidence interval limit mean plus minus 1.96 standard deviation divided by root over 9. As noted above, the confidence interval is inversely uh, related to the sample size. Increasing sample size, decreasing confidence interval indicate higher precision of the dataset. This is demonstrated in question 1. Both studies that link OCP use with liver mass report relative risk of similar magnitude. However, study B has wider confidence interval, which includes one which includes a value of 1. Therefore, study B has a p-value more than 0.05, does not reach the statistical significance. The explanation for wider confidence interval in study B is smaller sample size compared to the study size A. Can you please explain
Which one?
the number 1, question 1?
Mm, I got it wrong too, but it says that
The
basically if you have
Yes,
mhm,
you say
yeah, if you have a bigger size, a bigger group, then the confidence interval is tighter, so it's smaller. So bigger sample size, tighter confidence interval. Here the confidence interval is like 1.1 to 2.8. So that would be what? 2.8 minus 1.1 is like 1.7. And here the confidence interval for B is
2.7.
3.5 minus 0.8, 2.7. So here the confidence interval is wider. Here is smaller. So that means that
Wider confidence interval, lower sample size.
lower sample size. Yeah. So it's inversely. Yeah,
Wider
that's what it
confidence interval, lower sample size. And
is.
there is another relation they actually done, wider sample size.
Where? Mm,
Like clinically significance, increasing the sample size decreases confidence interval, indicating higher precision of the data set. Okay, these I need to remember. Okay, now explain question two. Okay, question two I have
oh,
got it.
you
Like,
got it. Yeah.
yes, and the question three
Mm-hmm.
in here, like we know
Mm-hmm.
subconsciously, like beta blocker has effect on the heart failure, not with the stroke.
Mm-hmm.
This is the clinical
Mm-hmm.
knowledge. And another thing, as it involves one, so in relative risk there is presence of one, so it is not affect the risk of stroke. That's the thing, isn't
Mm-hmm.
it?
It does affect the risk of stroke. Okay. Uh-huh.
Okay, you can explain
Okay.
if you want to say something, if you want to add something.
So what is the question? Wait, what is the question? What is your question then?
My question is, if you want to add something, like whatever you are telling about this biostat,
No, but
this,
you got why this is
yes, I got it. Is there anything what you have thought like
okay. Okay.
before dealing with this question? Like how you deal this kind of
Um,
question? Like how you
I usually
tackle
go
this kind of question?
I usually for this kind I just go one by one and like I just go one by one. I just a beta blocker this decrease
Like you read
both all
all the options and try to match
mhm,
with the
with
giving.
the thing. But yeah, but it usually goes I feel like it goes faster. Because here it says it will say I don't read the box at the beginning. I just read the question, I don't read the box and I just go straight to the answer.
Okay.
And then I go one by one. All cause mortality I already know they're asking, they're telling me beta blocker affects all cause and cardiovascular. That's all. That's all. So I go beta blocker, all cause. No, this is not true because there is no effect here. So I already know this. I don't even need to read the cardiovascular. I already know this answer is wrong because just the first part is already wrong. Because here it includes one. So there is no effect here. This is not statistically significant. So I don't need to check the cardiovascular. I know this is wrong. Then I go to beta blocker predisposes to stroke. I know this includes, I don't even need to read all of this. I know this includes one, so this is not true. This is not statistically significant. That is wrong. Then I go to C, beta blocker all cause mortality. I already know this is wrong because same thing from A. So this is I don't need to read the rest of the answer. That MI whatever. I don't need that. Then beta blocker exacerbate heart failure. Heart failure. Where is it? Heart failure, yeah, this is statistically significant. So yeah, they may be, but they decrease cardiovascular what was that, mortality. Cardiovascular mortality. Then it's like, oh yeah, that can also be the answer. Not really.
This is
Not
the
really.
answer.
That's not the answer because now
Why?
what you just said, that you because what you just said, that we know that subconsciously
Yes.
beta blocker cannot exacerbate. Yes. So we know that okay, but if you want
Beta blocker
to just look at the table, then both are significant. Mhm.
Beta blocker can actually
Protect
decrease
from MI,
cardiovascular mortality.
but mhm, mhm,
Beta
yeah,
block Beta
but you
blocker,
know that it doesn't usually exacerbate.
but beta blocker is
Mhm.
avoided in acute decompensated heart failure.
Oh, yes. So you would be probably between D and
D
E
and
between
D,
those two
yes,
answers.
this
Now you have D and E. So you just have to pick the one that is more
more
correct.
suitable. Yes.
But at least, yeah, but at least you've eliminated all the other ones just really quick. And then beta blockers protect from MI. Here we know we see is a statistically significant. So yeah, it's an option, but do not affect stroke. And we know here it's not statistically significant. So yeah, it does not affect stroke. So you probably just have to figure out between those two. But I feel like if you read it, you can see that this one is the one that makes more
More sense.
subconscious,
Yes.
makes more sense. Yeah, more sense.
Okay.
But at least, yeah, it's just quickly remove all the other ones without looking. Don't look at once you after you read the question. Don't look at the box because it's going to be a lot. Just go straight to the answer and eliminate. Yeah.
Okay, that's a good strategy.
Mm.
Okay.